Hello and good day one and all. Today we'll be discussing about the important topic in prosthodontics, which is the residual ridge resorption or RRR. Residual ridge is a term used to describe the shape of the clinical alveolar ridge after healing of bone and soft tissues after tooth extraction. So what happens is immediately after the tooth extraction, there is a cascade of inflammatory reaction which is immediately activated and the socket is temporarily closed by the blood clot. Then epithelial tissue begins its proliferation and migrates within the first week and the disrupted tissue integrity is restored. So here the residual alveolar ridge bone undergoes a lifelong catabolic remodeling. So the size of the residual ridge is reduced most rapidly in the first 6 months, but the bone resorption continues throughout the life at a slower rate. So this phenomenon is described as the residual ridge resorption. So this rate of residual ridge resorption is different among persons and even at different sites in the same person. So the mechanical aspect of this bone remodeling is usually associated with the Wolff's law of bone transformation, which states that every change in form and function of bone or of their function alone is followed by certain definite changes in their internal architecture, which simply means that the bone remodels in response to the force applied. So coming to the basic concept of bone and knowing its structure and its functional elements, which must be very clear before knowing the bone resorption or understanding the concept of it. So the structural elements of bone are osteocytes, osteoblasts and osteoclasts, which eventually participate in the bone resorption and remodeling process. Coming to the first aspect, which are the cells called osteocytes. These are small flattened and round cells embedded in the bony lacunae. They are the main cells of the developed bone and derived from mature osteoblasts. The main function is to help maintain the bone as a living tissue because of their metabolic activity, and also plays an important role in maintaining the exchange of calcium between bone and extracellular fluid. Now next, coming to the bone resorbing cells, which are the osteoclasts. These cells are the giant multinucleated cells found in the lacunae of the bone matrix. Their main function is bone resorption and are also responsible for bone resorption during the bone remodeling process. So bone resorption always requires a simultaneous elimination of organic and inorganic components of intercellular substance. Coming to the next cells, which are the osteoblasts, they are majorly concerned with the bone formation and are situated on the outer surface of bone in a continuous layers. Moving on to the next important topic, which is knowing about the amount and rate of bone resorption. So according to Boucher, he stated that during the first year after tooth extraction, the reduction in residual ridge height in the mid-sagittal plane is about 2 to 3 mm for maxilla, 4 to 5 mm for mandible, and the annual rate of reduction in height is about 0.1 to 0.2 mm for mandible and 4 times less in the maxilla. Coming to the next important topic is about the direction of bone resorption. Here the maxilla, as shown in the picture, the maxilla resorbs upward and inward to become progressively smaller, and the opposite is true to that of the mandible, which inclines outwards and become progressively wider according to the edentulous age. Therefore, RRR is generally more in the mandible than in maxilla, but the reverse may also occur. So we must treat the particular patient, not the average patient. Coming to the next important aspect is knowing about the pathology of RRR. Here the basic structural change in RRR is reduction in size of the bony ridge under mucoperiosteum. It's primarily a localized loss of bone structure. So in order to provide a simplified method, a system of 6 orders of residual ridge form has been described by Atwood. Now next, coming to the pathophysiology of residual ridge resorption. It's a normal function of bone to undergo constant remodeling throughout the life. It's a localized pathologic loss of bone that's not built back by simply removing the causative factors. Now coming to pathogenesis of residual ridge resorption. So what happens is immediately after following the extraction, any sharp edges that are remaining on the ridge are rounded off by external osteoclastic resorption, thus leaving a high well-rounded ridge. So as this resorption process continues from the labral and lingual aspects, the crest of the ridge becomes increasingly narrow, ultimately becoming a knife-edge ridge. So even if a great deal of residual ridge is removed in total, there is often a cortical layer of bone of the crest of the ridge. That means new bone has been laid down inside the residual ridge in advance. Coming to the next topic is the epidemiology of residual ridge resorption. So usually till date it would appear that residual ridge resorption is often occurs worldwide, often occurs in males as well as females, young as well as in old people, also occurs in sickness as well as in health, also patients with and without denture, and also is completely unrelated to the primary reason for extraction, which is caries or periodontal disease. Coming to the etiology of residual ridge resorption, so it is postulated that residual ridge resorption is a multifactorial biomechanical disease that results from a combination of anatomic, metabolic, functional and prosthetic factors, so which we will discuss in detail. Coming to the anatomic factors, it's postulated that RRR varies with the quantity as well as the quality of the bone of residual ridge. Therefore, RRR is directly proportional to the anatomic factors. Coming to next is the metabolic factors. RRR varies directly with certain systemic or localized bone resorptive factors and inversely with certain bone formation factors. So there are two different bone resorption factors which we'll be talking further. Coming to the next main discussion is about the factors involved, which are local and systemic. Now we'll be learning about the local factors. So they are starting from the endotoxin from the dental plaque, osteoclast activating factor, prostaglandins, human gingival bone resorption factor, and trauma due to ill-fitting dentures also leads to changes in oxygen tension. Coming to next is the systemic factors that causes the residual ridge resorption. One is the incorrect amount of circulating estrogen, thyroxine, growth hormone, calcium and phosphorus, vitamin D, hypophosphatemia, parathormone and calcitonin. So the imbalance in these factors in these hormones also causes residual ridge resorption. Coming to the next is the important factor, which is a mechanical factor which has 4 components in it. One is a disuse versus abuse theory. That means that bone that is used for regular physical activity will tend to strengthen within certain limits than the bone that is in disuse atrophy, while others postulated that due to denture wearing, RRR is caused due to an abused bone resorption. Perhaps there is truth in both the hypotheses, but the fact is that with or without denture, some patients have little or no RRR, but some have severe residual ridge resorption. Next is the RRR, which is postulated that is directly proportional to the force applied. So in considering the force, one must consider not only the amount of force but also the frequency, duration and direction of force, and also the area which with the force is distributed. And also the next is RRR is inversely proportional to the damping effect, which is the amount of force applied to the bone may be affected inversely by the damping effect or energy absorption. Coming to the next important is the prosthetic factors. So they are starting from the intensive denture wearing or long continued use of ill-fitting dentures, use of extended denture, excessive stress resulting from artificial environment, unstable occlusal condition, and also incorrect centric relation record. Coming to methods of evaluation, or how do we evaluate residual ridge resorption? One is to radiographic methods such as cephalometrics, panoramic radiographs. Third is to tetracycline labeling, mercury porosimetry, anatomic studies and rheumatic procedures. So yes, there are definitely there are consequences of residual ridge resorption, starting from the apparent loss of sulcus width and depth, the displacement of muscle attachment closer to the crest of residual ridge, loss of vertical dimension of occlusion, reduction of lower facial height, and anterior rotation of mandible, increase in relative prognathia, changes in intra-alveolar relationship and interalveolar relationship, morphological changes of alveolar bones such as sharp, spiny, uneven residual ridges, location of mental foramina close to ridge crest. Coming to next important aspect is the treatment and prevention. So treatment of RR is ideally by preventing it, that is by prevention of loss of natural teeth, proper design of denture and maintenance, and the nutrition. Coming to the next aspect is the tissue treatment therapy, which is by using soft conditioning materials to rejuvenate the tissue bearing area. Coming to the next part is the planning and performing the pre-prosthetic surgery, which include major corrections or surgical procedures like bridge correction involving soft tissue deformities or bone deformities, then bridge extension or vestibuloplasty, then bridge augmentation, and also surgical correction of maxillomandibular relations. Coming to last aspect, which is the important aspect of prosthodontic, which is the prosthetic management. One is through making proper impression, then the denture base selection, the importance of teeth selection and arrangement, and also planning for the implant supported processes. Hope you all understood the topic. Thank you very much. Have a good day.